Live stream. Thank you, Dhriti.
No problem. I'm just setting that up and then I'll make जिसको भी host बनाना है मैं बनाती हूँ.
Thank you so much.
No problem.
Live stream. Thank you, Dhriti.
Yes. No
Done.
problem.
Thank you.
Hi, Aparna.
ओके का एकदम व्यवस्थित वाटतंय
मस्त मस्त व्यवस्थित.
आहे ना
हो.
हा ठीक आहे मग मी आता परत हे करते तेवढ्यासाठी फक्त हे केलं होतं ओके हा
डॉक्टर मानसी डॉक्टर जयश्री किन किन को होस्ट बनाना है?
अब मैम जॉइन हो जाएंगी और अपर्णा को भी बिकॉज शी इज गोइंग टू आस्क द क्वेश्चंस.
Okay, so
Mansi,
should I
Mansi.
host or co-host? What status would you like?
को-होस्ट इज ओके ना. होस्ट मानसी को बनाएंगे तो भी चलेगा.
Okay, ठीक है.
मानसी यू विल
Done.
मैनेज ना. यू विल मैनेज.
धृती आहे तर काही प्रश्न नाहीये. मला फक्त धृती मॅडम ना होस्ट केल्याशिवाय नको बेटा तू ऑप्ट आउट हो.
हाँ धृति यू स्टे देयर ना.
Yeah. I'm staying here, so.
हाँ.
Okay, I will make both of you co-hosts also.
Yes.
Done.
Yes.
Yeah. Okay. Anything?
Even Dr. Mahajan is also going to join, so you have to make him also co-host once.
Okay, ठीक है. Done.
And
I
Dr. Arati Shahade will join.
अच्छा चलेगा. I think आप लोग के co-host status से you should be able to make them host, but anyway I am here. और आप दोनों को मैंने WhatsApp पे जो YouTube live का लिंक है वो भेज दिया है, तो you can share it जहाँ भी लगेगा तो.
Yes.
Done.
मी टाकतेच आहे सगळ्या ग्रुप वरती. जयू
Yes.
हा जॉईन करा म्हणून टाकते म्हणजे मग ते 100 पटकन झाले की मग पुढचं हे करता येईल ना.
हो.
Hello, JSP.
Hello, sir.
Hello, sir.
Yes.
Good afternoon.
Good afternoon, sir.
Yes, sir.
You are the co-host now. Dhriti is there, na?
Huh?
Dhriti has made you co-host now. Last moment glitches नको म्हणून.
Good. Me, everything is fine.
Yes.
I'm
So
joined
लवकर
by
आला का?
mobile. हा आता आलो लगेच म्हटलं मोबाईल जॉईन झालो. एक परत बाहेर पडून मी कॉम्प्युटरवर जॉईन करतो. कम्फर्टेबल होईल.
ओके येस येस.
आता बाकी काय, बाकी सगळं ठीक आहे ना?
हो बाकी सगळं ओके. आता मॅम जॉईन होतील, मग आम्ही पीपीटी जरा रन करून बघू म्हणजे व्यवस्थित होते का ते सगळं. Yes.
ओके, मग मी जाऊ, आय लिव्ह अँड कम बॅक.
येस
ओके ओके सर. येस येस.
मॅम जॉईन झाल्यात. शहाडे मॅडम, गुड आफ्टरनून मॅडम.
Yeah, just give me 1 minute's time. I'll
Yeah, yeah.
open this sentence.
या.
So when shall we start? Another few minutes or we start straight away?
Ma'am, within 5 minutes.
Yeah, okay. That should be fine. No problem. Just give me a few minutes. Then.
Yes.
Ma'am, shall we run the PPT?
That's what I'm trying to do.
Yeah.
Yeah.
Yes,
think-
ma'am.
Audible,
Yeah, it is visible. Yeah.
visible, right?
Yeah.
Should be fine. Give me some.
Yeah.
Whenever you want to say, start, we'll start.
Yes. We'll wait for
Yes,
3-4 minutes, ma'am.
Yeah.
मानसी,
हा बोल.
हॅलो. हा, महाजन सरांना परत जॉईन को होस्ट करावं लागेल. तर सर आता
धृती आहे ना.
लॅपटॉपमध्ये join.
धृती आहे तिथे. धृती.
येईल. ते लॅपटॉप वरून जॉईन झाले असतील आता.
तू आता जॉईन झालोय.
हा सर झालं.
हो,
हा.
नाही मला कोर्स नाही केलं चालेल का करायला पाहिजे. एनिवे
नाही.
माझं काही जरूरत नाही ना.
हा नाही. ओके.
धृती
नाही,
is
you're audible, sir.
yeah.
जयश्री माझं डोकं दिसत नाही वाटतं ना.
हो सर.
हा
थोडा
सर,
कॅमेरा
व्हिडिओ थोडा ऍडजस्ट
Adjust कर.
कॅमेरा ऍडजस्ट करा सर.
थोडासा अजून ऍडजस्ट करावा लागेल.
हो ना. ओके. हॅलो मॅडम. डॉक्टर महाजन.
Hello, sir. Namaste.
Mansi? Hello?
हा जय
अजून सरांना
करूया
विचारू
सुरू?
महाजन
करूया
काय
सुरू?
करायचं या
हा?
महाजन सर सुरू करायचं
Yeah, I think we'll start.
Yes, sir. Yeah. Sure. Good afternoon, friends. I welcome you all on behalf of Mukta Charitable Foundation. This is the third lecture organized by MCF in our monthly lecture series, which we started in December 2022. Our first lecture was on measles by Dr. Raman Gangakerkar sir, and second lecture was on common skin disorders by Dr. Vinay Kulkarni. And today, on the eve of celebration of 100 years of insulin, we are having talk on landmarks in insulin treatment by Dr. Arati Shahade madam. MCF is always trying to impart knowledge to family physicians on current topics and also according to the demand of family physicians, which is very helpful for all of us. And by seeing your enthusiasm, we are also eager to arrange many more series in future. Friends, I'm sure most of you are knowing about the work and projects carried out by Mukta Charitable Foundation. Let me just brief you about them. Mukta Charitable Foundation was established in 2005 by few like-minded people. It started working in the field of HIV/AIDS and by starting HIV Samvad Helpline. In 2009, it expanded this project to Bihar. Until date, we have been able to cater to about 4 lakh calls. Along with HIV/AIDS, our helpline also gives information regarding tuberculosis, hepatitis B, hepatitis C, and all sexually transmitted diseases. Along with this, we also started the project of addiction awareness for doctors, counselors, psychologists, and also in schools and colleges. In 2015, another project named Ankur was started for the disclosure of HIV status to the children affected with HIV to tell them the importance of adherence to the medicines. And here begin our project, One Shala Beyond Books, wherein from 8th standard onwards, the students are taught life skills, communication skills, sexual health, and addiction-related awareness. MCF is also working in gender sensitization project in various colleges all across India. Last year, it has conducted online lectures for various colleges in Pan-India. MCF is also running a first aid project along with Pratham Foundation for last 3 years, wherein students and people are taught about the importance of first aid along with the expert guidance from our MCF doctors. Now, MCF has also started Medical Legal Forum, where more than 200 doctors have registered and they're getting the guidance from our medical legal experts. Soon, we are going to start our mental health helpline, which will be useful to the society. MCF is also arranging now a certificate course in addiction medicine, which will be online and offline in Shreyas Hospital, Fursungi in March 23. The details will be shared to you soon in the groups. And MCF has always welcomed the volunteers and their suggestions, and we request you, all of you, to join us. With this, I now request Dr. Mansi Pahade to take the further charge of the session. Over to you, Mansi.
Yeah. Hello, friends. Good afternoon. Today, on the eve of this 100th year of celebration of insulin, we have eminent diabetologist Dr. Arati Shahade madam with us. Madam is MBBS MD and she has done her postgraduate diploma in diabetes care, Newcastle University of Australia. Fellowship in General Infectious Diseases, CMC Vellore. She is working as consultant physician and diabetologist at Shahade Hospital since last almost 3 decades. She is honorary consultant at Diabetic Association of India, Pune chapter. She is assistant professor in medicine, Bharati Vidyapit Medical College and Hospital from June 1996. She has worked in diabetes and endocrinology unit in St. Thomas Hospital, London in 2000. She is consultant diabetologist at KM Hospital, Pune in 2002 to 2003 with Dr. Chittaranjan Yadnik sir. She is examiner, Health Sciences Department, Pune University, honorary faculty, Symbiosis College, Pune. She is DNB teacher, guide and examiner. Organizing committee member, 5th National Conference of Indian Society for Parental and Internal Nutrition. She has multiple presentations, posters, publications, and textbook inputs to her credit. And last but not the least, she is a Kathak dancer, presented solo and group performances, and she is a very good painter. आता मॅडमनी कोरोनाच्या काळामध्ये पेंटिंगचा नवीन वर्ग जॉईन केले and she is a very good painter. So
Thank
she is talking on insulin today. Over to you, ma'am.
Okay, thank you very much. Thank you for that introduction, Manasi. And I must actually congratulate all of you on your human services that you do for the community. Actually, I'm humbled getting to know about your work in HIV and the addiction, etc. Probably they're much more important to the society right now than we treating a couple of patients here and there. So congratulations, keep it up, and naturally, I would also like to contribute whenever you feel I can do it. All right, fine. Thank you very much. So I think we move on to today's topic. So it's about insulin, and then as she said, this is the centenary year of insulin. Actually, not centenary year. For the discovery, it is 2021 was the centenary year. But this is the year when they received Nobel Prize, 2023. And this is the year when the commercial preparations of insulin started. All right. So this is a centenary year for that. So let's see what insulin actually, how we came to know about it, and how this behemoth disease, what we call as diabetes, was sort of being understood at the level of pathophysiology and at the molecular level. So that was the beginning of the journey. And I'm sure that it is not the end of the journey. We have not reached anywhere. So we will continue to do research. We will continue to apply science, and then we go ahead and try and treat patients for their betterment and for the betterment of the society in future. Right. So coming to, this is going to be a lot of, I should say this lecture is more of a history and very interesting, in fact. So let's see how it happens. Hey, बरं इतका वेळ हे काम केलं आता का करना. Correct. So how did we identify diabetes at all? Since it was sometime in 19th century, it is said that that the term diabetes became actually popular. But it was much before that. And let me tell you that we take great pride in telling the whole world that it was Charaka who made the first reference of this disease. And he rightly introduced it as something that is happening very sweet in the urine. And this happened sometime at 280 before Christ era. And well, there is some amount of mention about diabetes even in the papyrus in Egyptian literature. So if you look at it this way, like tuberculosis, probably diabetes is not a modern disease. As when I was a student, it was thought that the lifestyle diseases, that is hypertension, diabetes, are all new diseases, and they're occurring because of the revolution that occurred. Okay, that is the revolution which involved a lot of technology, and that is why people have become lazy, and then these are lifestyle diseases that we have got in turn. No, but then that is not true. This disease existed so long back. So what we know about diabetes probably is still the half-truth. In 19th century sometime, actually the pancreas were discovered by scientists. And a German scientist, Lanzaro, in 1877, he found out about islets of Langerhans, that is the islets that you see in the pancreas. And in 1890, Minkowski, von Mering, etc., they deprived the dogs of the pancreas, and then they thought that by depriving the dogs of the pancreas, the dogs will develop diabetes. So that is how the diabetes and pancreas were actually linked to one another. And around same time, say around 1901, Eugenie Opie, she was lady who actually discovered the damaged pancreas in diabetics. So from dog, we move on to the human beings. And this lady in autopsy, she realized that all those people who had diabetes had actually damaged pancreas. So from then on, the disease was linked to the pancreatic illness. That's about it. Then nothing happened in the next 1.5 decades. After that, there was a first attempt was done to isolate the pancreatic extract so that they could treat the high blood glucose. So what they did was they took the extract from the dogs. This was done by Polescu, and his experiments were mentioned in various journals. And then what happened, unfortunately, was this gentleman never got the due credit. And he's the first person who has done so far, because the First World War broke out. And then he just sort of he disappeared from the scientific scene, and he never became acknowledged. Nothing happened. So bad luck to the guy, right? But then what happened later on was that in around, say, 1920, that is about the end of the First World War, the gentleman, that is Banting, he just read about it, that there is something called as islets of Langerhans, and then there is something called as pancreatic lithiasis. That means you have got stones in the pancreas, and then that is related to diabetes, so on and so forth. That's about it, nothing more than that. But then, though he was not a scientist, or he was not a great clinician or anything like that, he wanted to put all his attempts and then isolate that pancreatic extracts and then use it. So what he did was he just went to the gentleman who owned a laboratory, or who was the head of the laboratory in Toronto University. And that was gentleman MacLeod. So the MacLeod offered him the laboratory facilities, and then he gave him dogs, etc. And Banting took the help of a fresh medical student called as Best. Okay. And then he initiated the procedures, and whereby he started finding out about the insulin. But remember, the present day insulin is all recombinant insulin. Okay. I'm just deviating from past to the present. Maybe we will move on to the future. I'll take you back to the past later again. See, now what we use is all synthetic. There is no pancreatic extract involved. So forget about it. So how did we reach this? Once we got to know about the polypeptide, or the protein molecular structure of the insulin, we started doing DNA, preparing the DNA by DNA cloning. And then you actually use this DNA, you insert it in the either in the bacteria or in the yeast. That should be YAST yeast, okay, not yeast. And it is purified, it is formulated, and depending upon the formula that you want. For example, if you want a very short acting one, you add something else. If you want a long acting one, you add something else to this basic polypeptide. And then you make different kinds of insulin. So this is what is happening today, all right? And then when I was just a student, all that we had was bovine insulin, okay? So this is not the recombinant insulin that you and I are using today. What we had was bovine insulin. What does it mean? It was actually came from the cow pancreas, all right? It came from the cow pancreas. It is, see, then why did we use the bovine? Because it is very similar to the structure of the human insulin, with very small differences here and there, but then it works equimolar. That means 1 unit of insulin, human insulin, is almost equal to 1 unit of bovine insulin, all right? So far as efficiency is concerned. That is why it was used extensively in the 20th century, all right? We don't even hear about it. Now, because it was a bovine protein injected into the human body, it became immunogenic, correct? So if it is immunogenic, if I put a protein in somebody's body subcutaneously, what is going to happen? It is going to initiate an immune reaction. So the patients are going to develop antibodies. There will be antigen-antibody reaction. So depending upon the antigen-antibody reaction, the insulin that you give in these patients will be nullified. So what used to happen is that these patients used to regularly develop hypos and hypers, because the insulin that you give might be nullified. Then in that case, the patients will not respond at all. But sometimes when the antibodies are low, they will respond. Okay. So this is what used to happen in the patient. So hypos and hypers were the order of the day in such patients. And remember, we did not have any glucometers. In fact, I myself had my first glucometer in 1993. It costed me a good 11,000 rupees. in Indian rupees, that is, okay? And each strip used to cost me 110 rupees. And all of that has to come from London. So it is not that it was very easy. So we used to actually do it in the laboratory, okay? The usual method that we used to take the patient's blood intravenously, and then there were no vasofix or scalp veins available at that time. It used to be very crude. So you had to draw blood, give it to the laboratory, check for the sugar, etc. So it was a very tedious business. Then at a later, say around at the end of 90s, the porcine insulin came, okay, around 80s and 90s. Again, similar to human insulin, everybody thought that they will be less immunogenic, so they became more popular, but unfortunately, the problems continued. We face the same problem like that of any other, say, bovine insulin. Now you'll ask me, why is it that we require insulin at all, right? What is it? It's like, when gold or lithium in the present situation. See, it's a small hormone. It's about 51 amino acids, correct? And then this is required to lower the blood sugar. How does it do it? It actually goes and attaches itself to the various receptors in the body, which allows the sugars to be entering into the cells. What are the cells? The skeletal muscles, the fat muscles, the fat cells, the skeletal muscle cells, and the liver mainly, right? So the sugar enters these cells and then it gets used up, right? So the blood sugar in the circulation will become less. So this is a simple phenomenon. So, but if there is no insulin, or if the insulin is ineffective, or if there is insulin does not work very well, inefficient, then the blood sugar will keep circulating. It will not enter the cells where it is supposed to, in the targeted cells. That is what it is, correct? So that is about the insulin. In the human body, the insulin is secreted in a very peculiar fashion, all right? So there is a small basal secretion that occurs over 24 hours. It's a small trickle that keeps coming from the pancreas. It will enter the pancreatic duct and it is secreted. The pancreatic circulation. So pancreatic vein, and then it enters the hepatic circulation, correct? So there is a small basal insulin. It enters the portal circulation, enters the liver. The first thing it does is, when it is in sufficient quantity, it puts off the hepatic glucose production. All right. So this is very, very important. So if you don't have insulin, the hepatic glucose production will continue unabated, irrespective of the ambient glucose concentration in the blood. Whatever may be the levels, it may be 300, it may be 30. The glucose production by the liver will continue. So you require a small amount of insulin, basal secretion, to take care of this phenomenon. In addition to that, when the patient is about to eat, there is a surge of insulin. Okay, there is a surge of insulin, which we call as meal-related surges, right? So you have 1 minute, I'll show you. Sorry. Yeah. So you have a small basal secretion, and then you have meal surge. These are the meal surges that you have. Is this important for us to know? Yes, of course. Because if you have got to treat, say, a T1 patient or a pancreatectomized individual, then your insulin, external insulin management should be in alignment with this pattern. It should mimic the natural phenomenon. So as I told you, you have insulin, which will attach to the insulin receptor. You have, say, GLUT4, GLUT2, so on and so forth. And then it will enter the, it will attach itself to the receptors, and it will actually, what should I say, stimulate tyrosine kinase, and then the rest of the things will happen. We will not go into that too. So why do we need exogenous insulin? We can understand that in those who have no pancreas or those who don't secrete insulin at all. That is in type 1. But in type 2, why do you need it? Look at this. This is the secretion of the insulin, correct? So this is the time when the patient is diagnosed. At that time, the beta cell function might appear to be adequate, correct? But as the years progress, the insulin secretion will become less and less. Mind you, it will become less and less even naturally, physiologically in every individual. All right, like how the number of the nephrons decrease as age advances, the beta cell units also will decrease as age advances. But it is not so drastic. It is a very slow phenomenon. Whereas in T2 diabetics, it is not only drastic decrease. In addition, there will be insulin resistance. That means whatever minuscule amount of insulin that is present, that will also not work. Correct? So these are the individuals who are going to require insulin. Now coming back to the story of Banting. So who got us that first? It was Polesco, but then nobody knows about him. He did nothing about it later on. We don't know what happened. So for us, it is Banting. Okay, so he discovered the insulin for the first time. So there's a small story behind how they ended up getting the Nobel Prize. So actually, the Nobel Prize for medicine, physiology, etc. are given after due diligence. They don't get it immediately. Suppose a discovery is done today, they will wait for a couple of years before they are given the Nobel Prize. However, here in 21, the insulin was discovered and they were given in 23. And it so happened that they first gave it to Banting and they also decided to give it to MacLeod. You remember, MacLeod is the gentleman whose laboratory was being used for the work, right? Now, what happened was this Banting gentleman did not like the idea at all. Whether you are a Nobel laureate, whether you are on the other side of the Pacific, all human minds and emotions all over the globe remain the same. All right? सगळ्याकडे मत्सर असतं, सगळ्याकडेही राग असतो, सगळ्याकडेही इगोस काम करतात. तसंच इथे पण झालं. So this man did not like it. So actually he went on fighting and then he said, why should MacLeod be offered Nobel Prize at all? All right? But then people did convince him that he also was an equal partner and he will also get the Nobel Prize. And then the MacLeod gentleman actually gave it to another gentleman who was working with him, that is the biochemist who actually purified it. Okay, so that is the Colic gentleman. So when he offered half of the Nobel money to that biochemist, Banting gave half of his money to Pest, who was a medical student at that time, who helped him in this experiment. So ultimately, the Nobel money was distributed amongst all four of them. See, as I told you, yes, Banting was a Nobel laureate. He did deserve it, every bit of it rather. We all admire him. Even after a century, we still eulogize him, right? And actually, what he said at that time is true even today. And it will remain true even for the next couple of generations. It is actually a very inspirational quote. He wrote, I'm a firm believer in the theory that you can do or be anything that you wish in this world within reason if you are prepared to make the sacrifices, think and work hard enough and long enough. I think this is the best quote I have read or I've heard in the near past. And when I actually was reading up literature for the today's lecture, I suddenly remembered this quote and then I found out and then I put it today over here. And all this happened in Canada, right? In Toronto University. So Canada actually released a stamp with Banting's picture on it. And this is the dog Marjorie on which they gave the first insulin injection, all right? A sick dog it was a diabetic dog on which the first experiment was conducted. So this was the stamp that was released in his name. Let me tell you, MacLeod was a Scottish man, all right? He actually disapproved of Banting's running about his laboratory and was it was really hostile to him in the beginning. He thought that this new guy, he has got something in his mind and then he just runs around and does something which is very stupid. And he did not give him too much of liberty to run around. And he just sort of tolerated him. And then he went on a vacation to Scotland, back to his hometown. And actually, when he was away, the experiment was conducted and came to the final levels. That is why Banting did not like MacLeod, okay? He has a reason for it. So when MacLeod went back after his holiday, that time the final round had come, and then he could see that whatever this Banting gentleman was doing actually had some truth in it. And there was some science behind it. And then he actively participated and conducted the experiments. And then he helped Banting. He went out of the way and helped him. That is the truth. And maybe that is why they were, hostile to one another for a long, long time to come. So in the first experiment was conducted sometime in October 31, 20. On 17th of May, 1921, they declared it as, they gave it to the dog and then also to a type 1 patient. And then they said that it is successful. And then they started producing commercially. It so happened that there were diabetics every part of the world, right? So there was a Dutch doctor couple who was present in Canada at that time, US and Canada. And then they came back to Europe, and then they took two NGOs together. And then by that time, these 4 people had patented it. They bought the patent and they started producing insulin in Europe also. And these people, they sold the patent later on to Eli Lilly. So Eli Lilly started producing insulin in US, Canada. And whereas Novo Nordisk, that is Novo and Nordisk, they are 2 NGOs which came together and they sunk in money and they started producing insulin in Europe. So that is how you have Eli Lilly and Novo Nordisk, 2 companies who dominate the insulin production and insulin there in research even today everywhere in the world. So now coming back to a bit of the history again, the landmarks. 1910, as I told you, they first find out that the insulin was missing from the pancreas. And the 21-22, the insulin discovery was done and was used in a 14-year-old boy. In 1946, as I told you, the insulin protein molecule, you add some, you delete some, so that you can actually manipulate the half-life of insulin. So you can make that insulin a very long-acting one. You can make that insulin a very short-acting one. So that is, today it is easy because it's a recombinant insulin. You can do it in the laboratory, right? Whereas in 1946, that could not be done. So this Hegedron gentleman, actually, he was also associated with Novo Nordisk in the beginning. So this gentleman added neutral protamine and zinc to the insulin that was available, commercially available, and then injected it. And he found out that the action of this NPH insulin lasted very long. Because by that time, we had learnt about the physiology of the insulin, and we were looking for something which we would call as basal insulin. All right. So this was the experiment which was done in 1946. Remember, not a very easy thing to do at that time. So 1982, human insulins came. I told you about bovine insulin, porcine insulin, and 82, it was human insulin. Remember, in India, we used to call it as monocomponent insulin and human insulin, so on and so forth. Even now, we call it as human mixed-tag, correct? It's not required anymore, but then we still write it like that because what we were using before was not human, right? So the human insulins became available commercially. So did human insulin help us in any which way? Yes, they did. Just 1 minute. Yes, they did help in the sense the immunogenicity of the insulin molecule became a little less. That's about it. But otherwise, it was all same as I told you, equimolar, the efficiency is the same, etc. And in 1996, okay, this insulin was, there was some manipulation was done in the protein molecules. So in the place of lysine, the proline was replaced, etc. And this insulin, which was manipulated one, it became a short-acting insulin. Then we call that as insulin lispro. Now, is it important? Why do we do it? Why do we require it? See, insulin lispro has a half-life of, say, a couple of hours, 2 to 3 hours only. Why do we need it? This insulin acts very fast. Its absorption in the body from the subcutaneous depot is very fast. So this was required in patients who had developed gestational diabetes, or girls, diabetic girls who had, who had steady sugars actually started becoming pregnant. So for them, this was important. So we started using insulin lispro preferentially in these individuals. All right. Similarly, another aspart was done. This is also a short-acting insulin. It came around, say, late 1999, available in India. Then in 2000, you had Iglar. Now from very short-acting insulins, you had a long-acting insulin. Till then, we had only NPH, you remember, right? So now we had Iglar. So this is a totally synthetic insulin, all right? And then it came in the 100 units. The other insulins are all 40 units till then, 40 units per ml. This is 100 units per ml. So it will remain in the subcutaneous depot, all right? And it will be released very, very slowly. So you have packed all these molecules and then you all these proteins and put it in the subcutaneous depot, and then it is slowly gets disintegrated. So this is a long-acting one. So it's a very good basal one. And because it is released very slowly, it does not reach a peak. So there is no peak. It's a steady line-like thing, okay? Basal. So it's done at the same level all throughout the day. So this was a very important one. Then again, you have another short-acting one in 2001. This is glulysin from Sanofi. Then the Novo Nordisk people, again, they founded another basal. They called it a Detamir. Detamir underwent a lot of trials. And this was one of the first long-acting synthetic insulin, which was permitted to be used, or which was permitted to be used in pregnant women. Okay, even today, though we do use Lantus, that is Iglar, Detamir has the license for use in pregnancy. All right, and then you had extra long ones, that is degludec. So this degludec has got a half-life of, say, more than 48 hours, right? So you expect its work to be there for more than 24 hours. And then you added aspart to it, right? Because when we think of insulin, I told you one is a basal insulin, then a meal-related insulin. So suppose you have a basal with a meal-related insulin together, stable, you give one shot. So what will happen? One meal will be taken care of. So instead of 2 shots, you have given only 1 shot to the patient. So you want to decrease the number of the shots to the patient, correct? So that is why you started having various combinations, okay? So these were pre-mixed insulins, what we call today as pre-mixed insulins. So you had Ideglira, then you had Ideg Asp, etc. Then you had in 2017 even a shorter acting insulin. The action of it will begin in a couple of minutes, will last only for an hour or 2. Okay, so this is a very fast acting insulin. So again, change in the protein preparation, or you add a bit of other proteins to it and make it get absorbed very fast. And once it is absorbed very fast, naturally it will undergo the metabolism very fast, and the action will also become less, or the action also will become less with given time, or it will stop after a couple of hours. So this was the need of the day in couple of patients in the beginning. So we do use all of them today. Now, what is the future like? See, in the future, we will be having insulins which will be very long acting. So for example, for 7 days. Now you have GLP-1 agonists which you give only once a week, correct? Similarly, you will have once a week insulins, all right? And then we will also have probably oral insulins. Yeah, in between, okay, we did have some kind of nasal insulins, all right? However, these nasal insulins, the whole experiment just did not take off. And the experiment was done in some centers, even in Pune, okay? But it did not work, unfortunately for us. So those nasal insulins were just out. Otherwise, we would have had inhaled insulins, because the absorption was erratic, the action was erratic, and then we just could not manage to use them. And I have seen the whole of the experiment from very close quarters, I know that it just did not take off at all. Oral insulins, well, we are still have very high hopes on it. But remember, proteins, when you give them orally, they are actually destroyed in the body, correct? That is why it is very difficult for us to make a protein preparations which can be taken orally unless you have coated it with something. Otherwise, the N by 10 HCl that is present in the stomach, it's going to disintegrate that protein. So you need to have some kind of coatings on them, which are usually tablets have, right? But then if you have that kind of a coating, when will it be released? Where will it be released? And what will happen to the intestinal transit time, so on and so forth. So we are still struggling with oral insulin. However, once weekly insulins are little, what should I say? They are appearing in the near horizons, in near futures. So even that will be very, very good for us. Now, where does India stand? So how have we managed as a country in this saga, in this history? Actually, we have, as I told you, we were way ahead of them. We did describe about diabetes. We did try our remedies for this. However, we did not succeed, or maybe we did not carry out the experiment. We did not continue to know about our own medicine when we were invaded by and colonized by Western people. Maybe, you know, in all that mayhem, we lost that science. We lost all our precious scientific belongings. And that's about it. So we all started again along with the West, unfortunately. So in 1982, we started having insulin market. And then, of course, insulin was available before that also, but then it started becoming freely available after 1982. Again, we followed the world, and then we got all these newer insulin. And now all these newer molecules are released in India simultaneously along with the global releases. So we are not very far off from anybody in this world anywhere now. Okay. You know that not every individual is same. Every individual's insulin requirements are different, and they differ in the same individuals at different times. For example, it will be different pre-operatively, they will be different post-operatively, right? They will be different when they're young and working. They're different when they are old and bedridden, so on and so forth. So you need to have different kinds of insulin that will suit the patient's needs. That is why there's so many of them are available in India. All of them have different onsets of action, peak of action, duration of action. You have a lot of basal insulins, that is NPH, glargine, detamir. You have glargine U300, D-gludec. All of them have different advantages and disadvantages. Similarly, bolus insulin, that is meal-related insulins, also are available freely in our country. And let me tell you, we also produce insulin, and some of the companies produce in India and actually export it worldwide. All right, we might not have made behemoths like Lilly or Novo Nordisk, but we are there. All right, we are there, and our insulin is exported to almost more than 50 countries all over the world. So we are good at it. Okay. Then I told you pre-mixed insulin. India is the country which likes pre-mixed insulins because we have a lot of carbohydrate meals in our food, and we prefer to use it because it matches our needs along with the meals. So we tend to use pre-mixed insulins more frequently than basal bolus insulins. We have now insulin analogs. All these Lispro, etc., are called as analogs. We also have what is known as biosimilars, all right, which are produced in India, and they're likely to be less expensive. So within the reach of all of our patients, all these synthetic insulins will have biosimilars, and these biosimilars will become available to everybody, all patients, hopefully in near future. It is not just insulin. How you deliver that insulin also is important. My uncle used to be, he was a very good businessman, a very successful businessman in Pune itself. Those who have studied in Pune will know that he used to supply all the glass instruments to all the laboratories around. He used to help NCL to produce chemicals and supply chemicals at one point of time. So He was even given a gold medal by the president at one point of time. This man had diabetes for nearly 30, 40 years. He died at the age of 80, okay? At 80, he used to take insulin every day. And then he used to go around the world. And on some of his journeys, I have accompanied him. And what we used to do is we used to use the glass syringe, and then, and then you have got to boil it and then use it, so on and so forth, right? It was so cumbersome that we had to carry that everywhere. And then he had to wait till that it was boiled and the insulin was pricked, and then wait for a couple of minutes and then have meal. So though it did not come in the way of his entrepreneurship, but I know that personally it was a very difficult one, right? So this syringe and then the insulin delivery system was present since 1924, that came along with the commercialization of insulin molecule. Later on, the Novo people, they had a better insulins, okay, the better syringes. So they had the piston, which was a little different. So it would allow the people to use it very freely. Then came the plastic ones, okay. So this is the ones, the Novo ones. Then came the plastic ones in around 1970s and 1980s. Then came the pens. So you have two types of pens, ones which are pre-filled and disposable ones. You can't use them again. Whereas you have got those pens, which are durable ones, you only have to keep changing the cartridges. So we use all of them now, okay? And then because of the environmental problems, right? Environmental problems, some of the governments did not allow these plastic pens to be used for a long time. So we started having the biomedical waste, we were talking about waste, disposal, and then we were talking about the plastic and recycling and so on and so forth. So these companies were asked to use the plastics which were recyclable. So the pens also underwent a lot of change. And then they were also asked to use more durable pens. That is why some of the companies are producing durable pens. Most of it is metallic, okay? For example, the Novo pen is metallic, right? The durable pen is. That is because now we would like everything to be environment friendly. Before this, we also had jet injectors, right? So it used to be at high pressure, okay? We could give insulin to the patient. So these jet injectors were present. However, again, like nasal insulin, these jet injectors did not prove to be very precise, and hence they were discarded, unfortunately. The whole idea was that the patient will not get a prick. It is the jet which will help the patient, the insulin, to enter the skin. But that experiment unfortunately failed. So now what is there in future? All right, you have insulin delivery system. In fact, now you have closed loops. You use all these insulin, the short-acting insulin and the ultra short-acting insulins in the insulin pumps, right? And then this pump is connected to the continuous glucose monitoring system, and both of them are connected through the Bluetooth. So depending on the ambient sugar, the Bluetooth will give it to the signals to the pump. You have an AI or the algorithm already embedded in the pump. So the pump will manipulate, or it will increase or decrease the insulin secretion that goes through the pump. Okay, so this is something like a closed loop. It's almost like that of pancreas, right? You can call that as an artificial pancreas. So this is what we are at now. This is at the other end. All right. You have the CGMS, that is continuous glucose monitoring systems, which will actually do an alarm if there is a decreasing tendency. They'll give an alarm if there is an increasing tendency. They'll wake you up at night, so on and so forth. However, let me tell you that there are a lot of patients who are still away from the basic needs. All right. So only 30% of the patients actually are managed with insulin. So suppose you have got 10 patients in your office who require insulin. Only 3 of them are offered and they're given insulin. But the rest of the 6 patients are not even being offered insulin. That is because of a lot of things that includes the physician inertia and also inertia on the part of the patients. That is, you give, but the patients don't take it. right? So this is what happens. That means 4 in 5 patients in India are totally uncontrolled. We do not reach the target HbA1c in say almost, I won't say 80%. I'll say that at least in 60% of the patients, we don't reach the target HbA1c. And many of these patients do not reach because we do not adequately insulinize them. All right. So it is important that you give insulin to these patients. And when you give that and you HbA1c decreases, you will actually reduce their incidences of both microangiopathies and macroangiopathies. It is very important for you to remember. So you don't have to wait for the patients to fail on therapy to start on insulin. If you think the drugs are not working, then add insulin. You need to educate the patient. You need to educate yourself how to manage the patient. That is very important. And I must congratulate all of you because you are here to educate yourselves so that you will have more empowered patients with you. And it will be easier for you to reach the goal at the end of the day. That is very, very important from my point of view. That's my perspective, right? So when you give insulin to the patient, you give rest to the beta cells. It also works as anti-inflammatory. Remember, it's an anabolic drug. Patients put on weight, they feel very energetic. There's some antioxidant properties, and it is in general cardioprotective and neuroprotective. So this insulin is necessary not just for the control of the sugars, but also for their well-being, okay, and for their longevity. So that is very, very important. So on that note, I close this topic today. And I thank all of you for your patient hearing. Thank you very much.
Thank you, madam. Thank you very much for such a wonderful and very informative lecture. And you made it is very simple for all of us because it is very, it is very difficult for us to understand the history, then evolution and innovation in insulin. So thank you very much, madam. Shall we start with question and answer session?
Yeah, please go ahead.
There are a few questions are there. How much weight, just 1 minute. 1 second.
No problem.
How did diabetes survive before insulin?
They did not survive. That was the whole problem. They did not survive. They were very short-lived. In fact, insulin came, that is why insulin was given the Nobel Prize. They did not survive.
Okay.
They had even after this, remember, even after the insulin was made available, because we could not control their macrovascular problems, microvascular problems, etc., their life was still short. Lifespan did not increase till the last decade. All right. It is only later on, with our better understanding of diabetes, that the lifespan improved.
Okay, ma'am. Okay, thank you. Thank you.
Then
Just
the diagnosis of diabetes was equivalent to death. That's about it. So you're not going to live.
Of long and short acting according to BSL, please describe.
Come again, please. The
Dose
long
of
acting and short acting.
long acting and short acting according to blood sugar level. Please describe over that.
See, it is not according to the blood sugar. Okay, it is not according to the blood sugar. You forget about blood sugar. Blood sugar may be 200, blood sugar may be just 135 fasting, which is high, right? You expect the fasting to be normal, near normal. So you want it to be around 95 to 100. It is still 30 more, correct? So irrespective of the sugar, you have to mimic the normal insulin secretion, correct? So I told you, I showed you that. So it should be something like that, correct? So what do? You have to give them a basal insulin, correct? And then you have to give them a meal-related insulin, right? So what we do is, sometimes we use pre-mixed ones. So you have 30-70. That means 70 is basal, 30 is pre-mixed. That you give 1 here and 1 here. You expect the basal insulin, which you have given in the morning, to cover this part. Correct? So this is how we manage. So there is, see, the long acting and the short acting, they are not related to the blood sugar levels. Okay?
Yeah, I got it. Okay, thank you.
Yeah.
Then
yeah.
what is the dose of insulin type 1 and division of basal and bolus?
Okay. In the type 1 patients.
Yeah.
See, type 1 patients, again, you remember this. Okay. Type 1, you at least have to give 40%, 30, 40. Some require 50% as basal. All right.
Okay.
The rest of them with the meal. So,
Okay.
in them, the basal requirement may be little more. Remember that. Okay.
Yeah.
And they have to calculate and take the pre-meal boluses. These are also known as bolus insulin or pre-meal insulin or
Okay.
prandial insulin. Prandial is meal. Okay. Prandial, bolus, short acting, they all mean the same. So they are to be taken before the meal.
Okay. Yeah.
Okay. So if you have a big meal, you take more. If you have a small meal, take less. In type 1, it works.
Okay.
Okay.
According to divide. Okay. Divide.
Correct. Yeah.
Next question. Non-diabetic admitted with some infection, example urosepsis. What is the choice?
Yes.
Urosepsis. What is the choice of insulin and how to adjust doses?
Correct. See, urosepsis is a critical condition. Usually, these patients are likely to be having even hypotension. Correct. So these patients are also likely to have hypoglycemia sometimes. They can develop diabetic ketoacidosis sometimes. All right. So don't go by the idea that the sugars will be high. No, not necessary. Sometimes they go, in fact, they go into hypos also. Some patients have that. Last week, I had a patient like that. Okay. So be careful. Yeah. In such patients, see, they're hypotension. So subcutaneous circulation will be compromised. So if I give insulin subcutaneously, it is unlikely to be absorbed very well. Correct? So what do? I have to give them IV infusion. So when I give IV infusion, you remember you have to give only short acting ones. You cannot give IV infusion using basal insulin. So you can use regular insulins for. Okay, some of them you can use, you can even use Lispro insulin for that. But what we use is regular insulin. Right? So this is what we have to do.
Okay. Next question. How much weight loss, how much weight does Humalog make you gain?
Humalog makes you gain. See, whether it is Humalog, that is Lispro insulin, whether it is Aspart, or whether it is, say, regular insulin, pre-mixed insulin, whatever that is, any insulin will produce weight gain. Because insulin is an anabolic hormone. Correct? That you have to remember. Number 2, see, most of these patients who are insulinopenic, that means who have less insulin before you've started on insulin, their endogenous insulin is low. They will have lost a lot of fat. They will have lost a lot of muscle also. The fat might remain, but they will have lost a lot of muscle. Correct? They will have become leaner than what they were.
Yes.
So once you start them on insulin and then the sugars improve, they put on weight.
Yes.
Correct? They put on weight because their sugars have improved, not because of the insulin. Because they stop losing through the urine. That is because they stop losing through the urine.
Okay, yes, absolutely.
Correct?
Okay.
That is why all that energy is gained back. So they put on weight. So any patient, irrespective of whether you are giving them glimepiride or insulin, when the sugars start becoming normal, they will tend to put on weight. So these patients have to be put on a diet where they are less likely to develop that extra kgs.
Here the diet play important role. Diet plays an important role.
Correct. And you must tell them to go see if the kidney functions are normal, etc. Go a little more on the proteins than on the carbs. They need to, once the sugars are coming to the normal levels, ask them to exercise. So you minimize weight gain. And you minimize weight gain.
Okay. Yeah, thank you, madam. What is the cutoff point to start insulin?
See, there is nothing like cutoff point for insulin. For example, what is the cutoff point for, say, type 1? What is the cutoff point for, say, pancreatic insulin people, diabetes people? No cutoff. If you are insulinopenic, you need it. Or else, usually this question is asked in relation to type 2 patients. Correct now? In type 2, when do you start insulin? In other words, see, suppose the patient is on 3 drugs, triple therapy, and the patient's sugars are not under control. Then what do? You probably add another drug. Correct? Yes. But if the sugars, if the HbA1c is 9 and 10, will it improve with the 4th drug? No, it is not going to happen. Because none of the drugs will reduce the HbA1c by more than 1 to 1.5. So if your HbA1c is 9, 9.5, despite triple therapy, that patient will require insulin. If your patient has got a fasting of 250, despite proper therapy, it calls for insulin. Why? I told you, insulin is secreted it goes directly to the liver. And what does it do? It shuts off hepatic glucose production. If the fasting of the person is 250, that clearly tells you that there is no insulin.
Yes.
Correct?
Yes.
Patient has been given 3 drugs. Most of the times it includes 1-sulfonylurea, which is a stimulant of insulin production and secretion. It is not working.
Correct.
What are you waiting for? You have to start them on insulin.
Yes. Okay. Thank you. Basal dose more effects in morning or evening. Okay. Yeah. Basal dose more effects somewhat like that only.
Wait, you want me to read it?
No.
She has answered it. She has answered it. Aparna, next question.
Yeah. Okay.
What is the function of basal?
What is the function of basal insulin?
Yeah, I told you, basal, this is again, I told you, basal insulin is the one which will stop the extra hepatic glucose production, right? And it mimics your natural insulin production in the body. It has to, it is in the same pattern as that of normal physiology, correct? So you have to give basal insulin to these individuals.
Correct, okay. Can CGM help in dose regulations?
But when it is given,
Who is also
more
Can CGM help in insulin dose regulations?
100%. 100%. CGMS is to be done according to the recent most guidelines in T2DM patients, even if they are on oral therapy, at least twice a year. Okay? Because patients then will realize what is happening with them. They will also come to know what happens if they eat one plate of uppit, or say 1 plate of shira, or 1 banana, or say 1 cup of milk. All that will come, the patients will come to know by themselves. What are the pre-meals? What are the post-meals? What will happen to them? So on and so forth. So in fact, that is a time when we come to know whether the patients have got hypos, whether the patients have got increased secretion, that is increased sugars after the hypos, so on and so forth. So yes, CGMS fine-tunes, okay? It fine-tunes your treatment. So it is essential at least twice a year in a T2DM individuals, more frequently in individuals who are on insulin.
Okay.
Actually,
okay.
At any given time, at least 2 or 3 of our patients are going around with CGMS now. We call them as trackers. Okay. The paramedic staff calls it as trackers because it tracks your sugar levels. So they are called as trackers. So these patients are with trackers, and then they keep taking the readers, and then they just have to, take near the sensor and then know what the ambient sugar is. So every 15 minutes, you can make out what your sugar is. So many times these patients will be admitted in some other ICUs, and then, I get to know their sugars from here itself. Madam itna aya, madam utna aya, so on and so forth. So these are trackers. Yes, they're very interesting. And they will also, you don't require to teach them much, because they understand what happens if they miss a tablet, what happens if they, they do not adhere to the diet, or if they don't exercise. त्यांचं सगळं जातक तिकडेच सापडतं, त्यांनाच सापडतं, in a language which they understand. So, we have got to less work there. Yes.
What is the ideal value of HbA1c in type 1 diabetes?
What is the ideal?
value of HbA1c.
See, remember, as near as possible, as normal as possible. But in T1 diabetics, it is very difficult unless these patients are on pumps. Okay, so it is very difficult even with pumps for us to get them at 8 is, it's great. It is very difficult for us to actually maintain their sugars. They tend to have a lot of hypos and hypers, especially if they're children. So we struggle with it. For them, of course, ideally 6.5, they're small. It is 7 if they're old, right? Same thing. It's not different for them.
Okay. If basal insulin taking care of neoglycogenesis by liver, especially in early morning, only why we need very long acting injections?
See, that is because you take the injection at night and you want it to work the whole throughout the night. So that's about more than 8 hours. So naturally, you want a long acting one. And you don't want a peak, because then if it peaks sometime, the sugars will go down. You will be sleeping at that time. Then who's going to feed you? Right?
Yes.
So you want a smooth working basal, peakless insulin. So you take it at night.
Okay. In post-op diabetic patient, should one follow insulin chart?
In post-op diabetic patient, see, there is nothing called as insulin chart. There is nothing called as insulin chart. See, post-operative patients differ. For example, today we had one patient, spinal anesthesia, surgery which is not related to the gut. This patient is likely to be NBM since morning. So since morning, no insulin he had, except for small basal, correct? Otherwise, they are likely to go into diabetic ketoacidosis, right?
Yes.
And then in the evening, he's going to eat. Depending on what he's going to eat, I'm going to give him a small amount of insulin, depending on his sugars also, right?
Yes.
If his sugars are only 90 and he's going to have only a cup of tea or coffee, I'm not going to give him any insulin. There is no chart as such, and it differs from patient to patient. It differs from surgery to surgery, right?
Yes.
For example, somebody who has undergone an extensive intestinal surgery, right? For them, you have got to match it with their meals, that is rice tube meals, right? Many of the times they are NBM. So there it is a nightmare. There you will have to use short acting ones. You have to use basal insulin, so on and so forth.
Okay. I think we have covered all the questions, I think. Yes, Dr. Mansi?
Yes, questions are over now. Over to Dr. Prakash sir to sum up the session.
Yeah. Now, thank you very much, madam, for such a informative, and you made it very simple and for all of us. Thank you very much, ma'am. Now I request Dr. Mahajan sir to conclude our session. Thank you, ma'am.
Madam, the second best thing I liked about your lecture today was, the first one, of course, was dissipation of scientific knowledge about insulin. The second best thing was about the Benting and Best and the McLeod controversy. It was just like a story. And you're deeply interested in that. You told it so
actually, when you read it, sir, you feel very happy. Because see, everybody else, even if they're very intelligent, even if they're Nobel laureates, they're also just like you and me.
Right. Yeah, that is. And in about those three, I really don't know who was the best. But I think today you are the best.
Thank you very much. Thank you.
And in passing, I'd like to mention, you mentioned that diabetes is not a modern disease. You mentioned something about
It was described by Charaka, sir.
It was described by Charaka. See, I just sometimes reflect, we read about Gita in the Indian context. How did Sri Krishna die? Sri Krishna died when everything was over, right? His obligations in this world was over. He was just lying in a jungle, and there were cows who were surrounding him. And an arrow came, and he was just lying down, and hit his foot. Yes. And it is described that then his foot, it became gangrenous. I mean, became dark, and he died. That was
yes.
So, is it possible that Sri Krishna was suffering from diabetes?
Sir, I think he had some kind of congenital heart disease because he's blue.
Okay, he had
blue, right? Yes, he died very early. As you said, probably that was his Achilles heel.
Right.
Very likely.
Very likely. If you know about Kumbhakarna, He described that he used to sleep for 6
Yeah.
months. Then
So he
used
must
to
be
eat
having sleeping
voraciously.
sickness.
Then pass
Yes.
urine, so it was polyuria. Ki someone kunda bharun jaisa. So, and he
Oh.
was hefty, almost 150 kg like that. He also probably was suffering from type 2 type of diabetes. That is
Correct.
also right. So
And
diabetes
he
is
was
not a
sleeping all the time. त्याला बहुतेक obstructive sleep apnea असेल sir.
So thank you very much. खूप छान
Thank you
झालं.
very much,
And
sir.
you made a
Thank you and
judicial
congratulations. तुम्ही खूप छान
judicial
काम करता
combination
sir.
of science and history. We loved it. Thank you very much. And thank you, Jayashree. Thank you, Mansi. Thank you,
Yes.
everybody.
Yeah, yeah. Actually, I got to meet all my friends after a long time today, though it was a virtual meeting.
Thank you so much, ma'am. Thank you so much.
Thank you, ma'am.
Have a
Take
great
care.
weekend, everybody.
Chalo, bye.
Yes.
Yes.
I'll leave you.
Okay, sir.
Yeah,
Thank you.
yes.
Once you can end the meeting.
Yeah.
Nancy? Hello. Do you think you can end the meeting? Means actually कैसे करना है? हाँ. Yes. Yes. Yeah. Thank you. Yes. Yeah.